Welcome to our third roadshow, regional roadshow. We're slowly working our way across the country because we very much want to be representative of the whole of the UK, not just London where I was based. And we do want to welcome you all to join our community. We help each beneficiary, but we also believe we want to help our colleagues who are trying to care for you beyond the cure itself. And welcome, we're delighted to be in Nottingham, and thank you for welcoming us here. I'm a paediatric endocrinologist, and I worked for 25 years at Great Ormond Street and University College London, trying to look after survivors once they'd been cured, and increasingly recognised that those with brain tumours were particularly vulnerable. And it's taken me a long time to work out that they not only have a brain tumour, which is often not malignant, so they're different from other cancer survivors in that way, but they also have a brain injury, which wasn't recognised as such and was generally called a late effect of treatment, usually radiotherapy. And I've increasingly become to doubt that we've understood that. And so as a holistic paediatrician, I wanted to help children recover what was often a broken life that others didn't see. And so success was founded as I was nearing retirement to make sure we left no child behind, either in terms of their sexual maturation as well as their intellectual maturation, and to cure the brain injury as well as the brain tumour from the very beginning, now that 4 in 5 survive and live long lives. And the 3 pillars of our strategy are research, awareness and support. We want to accelerate NHS reform and innovate services. We want to amplify the survivor voice and advocate for change. And we want to alleviate the social isolation that these young patients report. And actually, this idea that rehabilitation was necessary is not new. And in 2005, the NICE Cancer Guidance, which we together formed, stated that brain tumour patients are likely to need rehabilitation, perhaps for the rest of their lives. And it does make a difference and may actually avoid later costly complex care packages. But 20 years on, we know that this is very sporadic, it's inconsistent, geographically, it's reactive rather than proactive. And we estimate that there must be some 40,000 such survivors across the UK now who had a brain tumour under the age of 25, and which we would like to connect with. And we've been running a survey on our website to hear from you, to try and get that information. It's called, there's a survey that you'll see, and we're lobbying for change to try and understand what the problems are. There are 700 or so new brain tumour patients every year. The survival has plateaued for the last 20 years despite all the investment in research, so it's the wrong outcome measure. We don't know how these young people actually live, and we believe that some of the endocrine and neurological injury that we've called late effects is actually predictable from the beginning according to where the tumour is. And we also know now there's data coming in that there's frequent NHS rehospitalizations, and we want to improve the loss of education and employment, both of young people themselves who will live another 60 or 70 years, and their parents who are caring for them. So actually, if we did this right from the beginning, we hope to save the NHS money and the public health. So this year we have put in both a submission to the NHS Cancer Plan and to the Department of Health and Social Care Children's Task Force for Cancer to argue that we need a parallel recovery service which acknowledges neurorehabilitation and endocrinology for every child from the very beginning. It may need enhancement for those in the deep midbrain. I'll show why. And there are some very rare pituitary tumours which affect 30 to 40 in the UK every year, so it's exceptionally rare, that require a bespoke service, which adults get, so why shouldn't children? And we believe that these children will actually do much better in the longer term, and we'll be discussing that later. But it does need early investment in the right workforce. If we can get the right people doing the right treatment at the right time, in the right place, it will actually improve outcomes and save money. So the current recovery pathway that we've been trying to develop over the last 2 years, the top pathway shows the classical late effects pathway that we've been working to in general cancer, where the oncology team gets together, they decide the treatment and apply it. They wait 5 years because that's the outcome. If you live 5 years, that's a cure. And then you monitor the late effects of the presumed treatment in a surveillance clinic. Well, that doesn't work for brain tumors. It's a waste of the time that you could be rehabilitating the child. They tend to come back. Some of them never go away. Some of them never stop treatment. And so the endpoint isn't clear. And many of them are low grade, i.e. benign histologically, but they're malign because of where they are in the brain. So we're proposing a separate, parallel pathway that honors the services these children need in neurorehabilitation and endocrinology and other aspects, but those are the key individuals, that starts from the beginning and assesses children right at the beginning and follows them through key stages across life. That way we will know what the problem is at the beginning, what the rehabilitation recovery plan should be, and therefore decide better what is a treatment effect and what is actually a tumor effect. And that will have an impact on the treatments that the doctors will provide. And we also believe we should be supporting our neurosurgical colleagues better, because however well they do, surgery also takes out a tumor, but it causes an injury. And we need to rehabilitate that to maximize the wonderful work we're doing. And the two pathways will be connected by a success advocate or key worker who will make sure those children get coordinated care and get referred into the services. And this is a pathway we're trying to work with our colleagues at Success Connect. It's an endeavor we've launched with recovery professionals to try and tailor this program. This is the data that's coming out of secondary hospitalizations of childhood cancer survivors. The arrow points to the brain tumors. The top bar is leukemia and lymphoma. And you'll see that apart from tumor readmissions, the next common causes for readmissions are endocrinological in green and neurological in brown, with neuromuscular in dark blue. And there's a worrying small bar of, in both, particularly leukemia and brain tumors, of suicide risk. And that's worrying and sad, and we do hear about this. Why I'm an endocrinologist. I think that we've forgotten the midbrain and its vital importance, because it's a very difficult area to study. And you'll see that the pituitary gland, which is the small little bulb, is outside the brain, reached through the nose. It's connected up to the hypothalamus, which we can't see on a scan. And that constitutes the life center of everything you take for granted: how you sleep, how you wake, how your temperature is controlled, how your blood pressure is controlled, when you're thirsty, when you're hungry, when your breast milk comes out, when you're sleepy, how you grow. And this is a vital. Hormones are simply the body's messages, and that's the post office. And the post office sends letters to all the glands in the body, which are the homes, and those tend to be affected by chemotherapy, whereas brain tumors tend to affect the central part. And trying to understand what is what in this complex situation takes quite some doing. And optic pathway tumors, which start across from the eye and go through the hypothalamus to the back of the brain, also invade this pathway. And it's a dynamic pathway and very important. And it's taken a very long time because these tumors are rare, but I'm very proud of the study that we published in 2022 following all the youngest children under 3 diagnosed with optic pathway and hypothalamic gliomas. It's the largest and only worldwide study. You have to follow children across the maturational span to see the evidence, and what you will see is that tumors come in different areas. The survival is high at the top, the overall survival, OS, but there's a fall off late in life, which is blamed on tumor, but is likely to be life-threatening endocrine deficits. And the endocrine event-free survival, EEFS, is low and continuous, and it has to do with recurrence of the tumor, not so much the treatment, which unfortunately hasn't worked in these children. And I think this is an endocrine tumor that requires more endocrine input, and we need to educate each other. So the other odd thing about midbrain tumors is that survival's always been high, even the cancers on the right, which don't involve endocrinologists, particularly at the beginning. We've done new guidelines for the pituitary and the craniopharyngioma that we're trying to see implemented, and that's the optic pathway gliomas I was talking about. So we have really tried to hone down on what we're requesting from government, and we've suggested that the vital component should be a key worker from the beginning, so that children have a personalised plan which involves both neurorehabilitation and endocrinology. And that means we're going to need to expand our current services in this area, including in the community. And I think that young adults need a different assessment as they move into adulthood, because they also need to be educated, and we need to hear from them. They now have a voice. So only then would we be able to achieve a quality life. And we believe that it is unethical any longer not to offer recovery as part of a mandated part of cure. We're not curing them unless we do both the brain injury and the brain tumor. And we want to get it right first time. And we need to collect better primary outcomes which reflect that, and achieve equity of care for those with very rare diseases, and ultimately give parents more informed choice about the recovery options. Thank you very much.